Are we beginning with parotid or thyroid? Let's do thyroid 45 minutes and parotid 45 minutes.
Okay, sir.
Sir, I think Ronald's will be first. Devendra sir is asking for thyroid first.
Okay, all right.
So we'll do that first.
So what were you got? Prathamesh is also joined in. Good evening, sir.
Good evening, Devendra.
Hi, sir.
Good evening. So you want the thyroid first? We'll take the thyroid first.
Good evening, sir.
Good evening, Prathamesh.
Hi,
Dr.
Karan.
Shiva is also going to be here.
So I believe he'll be joining in, sir.
Is Dr. Shiva here?
Not yet, sir, but I believe he's joining.
Can't hear them.
Not yet, sir, but I believe he's going to join in.
Prathamesh,
Yes, sir.
is Dr. Shiva going to be here?
So I'm not seeing him on the participants list yet.
Devendra
he's
mentioned
joining
that
in.
he's going to be tackling the students today.
Okay. So I was not aware, sir.
Okay.
So Prathamesh, can you hear me? Hello?
Yes, Devendra?
Yeah, I've sent it to Shiva, sir, the link. I think he'll join in, sir.
Okay, all right. Okay.
So Prathamesh, I thought that since we have both have quizzed on thyroid and parotid earlier,
Yeah.
I thought one new person, you, me
Sure.
and Kannan have taken last time. So I thought a
Right.
new person can bring in some fresh questions.
Right. Good.
So both the DNB surgical oncology candidates want a mock exam, and they want to be tested by the best experts from the Tata Memorial. So I think that Ronak will first present a goiter, and after that Kushal will present parotid. And I think that they tell me that they are given 40 minutes in the exam. So we'll try and abide by that kind of a timing so they get the sense of what they're going to face in the exam. Okay,
Right, sir. Right, sir.
thank you. So yes, Ronak, please start.
Yes, sir. So you able to hear me, sir?
Yes.
Good evening, teachers and my colleagues. I'm presenting a case of thyroid swelling. A 32-year-old lady, a homemaker by profession, resident of Navi Mumbai, presented to us with a complaint of swelling in front of the neck past 2 years. The swelling is insidious in onset, gradually progressed to the present size. Not associated with pain. There is no history of sudden increase in size. There is no history of symptoms suggestive of hypo or hyperthyroidism. There is no history of dyspnea, dysphagia, or hoarseness. There is no history of weight loss, weight gain, palpitations, fever, generalized weakness. No history of radiation exposure in childhood. There is no other neck swelling. There is no history of which is suggestive of metastasis like cough, breathlessness, and bony pain. The past history, she is not taking any kind of thyroid medications, no comorbidities, and no tuberculosis exposure. There is no family history for this cancer in this first or second degree relative or unexplained death. Obstetric history, gravida 4, para 4, all full term normal delivery. Menses are regular, normal flow, 4 by 28 days, painless. Her last menstrual period was 15 days back. In the personal history, no substance abuse, normal bowel and bladder habits. Sleep pattern is normal. She takes iodized, mixed diet, educated till 12th standard. So my summary, according to the history, is a 32-year-old lady who looks clinically euthyroid, presenting with the anterior neck swelling, which is probably a thyroid, which can be benign, which appears to be benign in nature, and, another possibility of malignant thyroid.
Why are you saying both the differentials in your provisional diagnosis?
So first thing is young age, like 32-year-old lady with a 2-year history. So that with no other symptoms of loco-regional or any kind of distant disease, which favors of benign disease. And so there are some low-grade malignancies in thyroid, which can be there for a long time. So I keep both the differentials in my this as per the history.
What is the incidence of thyroid malignancies in a general population?
So I don't know the exact data, but if I have to guess, it's 20-25%, 20%.
So how do you talk about data when you're talking about incidence,
So the
prevalence? What is the prevalence?
yes, so this ICMR data is there. We have to talk according to that.
So you need to know this when you're presenting a case. This is how they're going to ask you in the exam, right?
Yes, sir.
So you cannot give two possibilities when you're talking about a 32-year-old lady having a euthyroid swelling for the past 2 years. What are the signs of malignancy?
So signs of malignancy will be old age, rapidly increasing in size, then hoarseness, dysphagia, this involvement of the aerodigestive tract, or maybe this another swelling in the form of lymph node which is present, or distant mets in the form of cough, breathlessness, or bony pain, which suggests malignancy.
So what, does she have any of these?
So she doesn't have that.
So don't put your foot in it and mention all this.
So then this appears as a benign swelling, thyroid.
All you have to say is whether it's a solitary nodule or a multinodular goiter, and you have to say, I need to investigate this further. You don't have to put your foot saying that, that this is a benign or malignant. You don't know that. So you say it is a nodular goiter or it's a solitary nodule or a multinodular goiter.
Okay, sir.
Okay. So taking Prathamesh's question ahead, is there a difference in the malignancy rates between a solitary nodule and a multinodular goiter?
So long-standing multinodular goiter can lead to follicular carcinoma, and 30% of the malignancies present as solitary thyroid nodule.
No, I'm asking you the reverse. If you see a solitary thyroid nodule,
Yes,
will you
sir.
think that this is malignant versus a multinodular goiter? What is the difference in the incidence of malignancy in a solitary thyroid nodule, a patient presenting with a solitary nodule versus a patient presenting with a multinodular goiter? Is there a difference?
It is higher in solitary thyroid nodule as compared to multinodular.
Where do you get this data from? Is that correct? Is it all over the world, or is it only in some parts of the world it is higher?
Sorry, I don't know this.
Okay, so most of the cases, the incidence of malignancy in a solitary nodule versus multinodular goiter is the same, except in iodine deficiency areas where it is higher. Okay?
Okay, sir.
Solitary nodule. All right?
Yes, sir.
Okay, go ahead.
So what will you do?
So I'll do the general physical examination and the loco-regional examination, and
Right.
so
Go
patient is conscious. So should I proceed, sir?
Yes, please.
Patient is conscious, cooperative, and well-oriented time, place, and person. Febrile. Pulse is 70 beats per minute. Regular, rhythmic, normal volume. BP is 110/70 mmHg. Respiratory rate is 16 per minute. Regular. There is no pallor, pedal edema, or generalized lymphadenopathy. ECOG performance status is 0. Moderately built, and her BMI is 23.4 kg per meter square. There's no signs of hypo or hyperthyroidism. No eye signs, tremors seen in the hand or tongue. No pretibial mixed edema. Spine examination is normal. The systemic examination is within normal limits. Coming to loco-regional examination on inspection done in front of the patient, sitting at the level of patient. 6 by 5 vertically by vertical cross horizontal, spherical, smooth swelling in the entire neck, predominantly on the right side. Swelling moves with deglutition, does not move on protrusion of tongue. Overlying skin is normal. There is no sinus, discharge, dilated veins over the neck. On palpation, there is a well-defined, non-tender, spherical 7 by 4 centimeters swelling in the entire neck on the right side. Rest of the gland is not palpable. Coming to the extension, it's 2 finger breadth below the hyoid, 1 finger breadth above the suprasternal notch, laterally up to the entire border of the right sternocleidomastoid muscle, and medially reaching up to the midline. Lower border is palpable. The overlying skin is normal. The swelling is firm in consistency, smooth surface, uniformly. There is no palpable cervical lymphadenopathy. Bilateral carotids palpable and undisplaced. Trachea is central in position. Auscultation, there is no bruit heard. The ideal reveals that the bilateral vocal cords are mobile. So, summarizing my history, there's a 32-year-old lady with a 7 by 4 centimeter solitary thyroid nodule of the right lobe of the thyroid, past 2 years, clinically euthyroid, with no symptoms, pressure symptoms, suggestive of benign etiology.
You said no family history. What is the importance of family history in a thyroid nodule?
So family history, there are a few syndromes which are associated, like familial FAP syndrome, familial adenomatous polyposis, and second thing is this Cowden syndrome, Gardner syndrome, Carney syndrome. Then other syndromes, men's syndrome, medullary thyroid carcinoma is there. So these syndromic things I have to see. Other than the thyroid, I also have to see for the colonic malignancy, if the patient has or in the family member, or any kind of.
Wait. So familial is more common in medullary, correct?
Yes, sir, it's more common in medullary.
Right. What percent of differentiated thyroid cancers are familial?
So approx 8%, 8 to 10%.
Right, 5 to 10%. That's good. Okay, go ahead. Can you tell me the characteristics of a thyroid malignancy in familial? Is it different from routine cancers that you get?
Devendra, you are not audible, Devendra.
Ronak, can you tell me the characteristics of thyroid cancer in a familial setting? Is the presentation different?
So clinically, sir, this one.
Clinically, yes, clinically.
So clinically, they will present early, sir.
They present early, then they present early. It's a small nodule, or is it the reverse? Exactly the reverse. They are more aggressive at presentation.
Yes, sir.
Okay.
Yes, sir.
They present in a more advanced stage. The chances of lymph node metastasis are higher. Okay.
Yes, sir.
Right. So when do you call a patient? How do you say that this is familial without doing genetic testing? How will you know? You said you've taken family history. What family history have you taken? How many members in the family should be affected to call it familial cancer?
So 2 or more first degree relatives, if they have this.
Right. So 2 or more first degree relatives have generally constitutes familial cancer. Okay. Very good. Go ahead. What will you do for this?
Yes, I've done with the history. So after this, I'd like to go for this TFT, thyroid function test of the patient, which includes a free T3, T4, and TSH, and routine blood investigations, and the X-ray neck, epilateral, and chest X-ray PA view. And along with this is a euthyroid state. I'd like to go for a neck Doppler, sir, ultrasonography, and a guided FNAC.
Neck Doppler. Why do you want to do a neck Doppler?
Neck ultrasound neck, sir. Sorry, ultrasound.
Very good. Ultrasound neck. Okay. What will the ultrasound neck tell you?
So ultrasound is a extension of this clinical examination. It will tell me it's from the thyroid. It will confirm my clinical diagnosis, and ultrasound will tell me that what is the extension. Is there any extrathyroidal extension? Is there any lymph node which the subclinical lymph nodes if present in the lateral group or central group of this central region, central compartment, and Yes, sir. And it will tell me that how many nodules are there. It is a single in the it's in the one lobe of the thyroid, or both the lobes are involved.
Is there a specific way the radiologists report the chances of malignancy in an ultrasonography?
So they report in thyroids. Yes.
Thyroids. Very good. So what are the features of a follicular carcinoma?
So follicular will be isoechoic, round. So these are the and increased vascularity.
Yeah. So generally on ultrasound, you cannot diagnose follicular carcinoma. Why papillary have microcalcification, irregular borders, hypoechoic, and taller than wider. On the follicular carcinoma, the isoechoic, round, and they don't have microcalcifications. Okay.
Yes.
What are the features of a benign nodule on ultrasonography?
So benign will be cystic.
Purely cystic.
Purely
Yes.
cystic, yes, sir. And borders are regular. They don't have microcalcifications. It's wider than taller and hyperechoic.
More importantly, they're spongiform. Okay.
Spongiform.
Great.
Sir.
Right. So you have ultrasound, you have thyroids. What next?
So this is the ultrasound, sir. So in this ultrasound, they found this the one which was palpable. It is 6 centimeter nodule on the right side. It's a well-defined isoechoic solid, wider than tall nodule without internal calcification. And they found another nodule which was 0.6 centimeter on the opposite lobe, which is irregular, hypoechoic, wider than taller with internal calcification. So the one which we were palpating was thyroids 3, and the one which we couldn't palpate is thyroids 5. They've reported. So this thing.
What is the size of the thyroids? 5?
0.6 centimeter.
0.6. So what do you want to do now? Ronak, let me tell you, Dr. Shiva has joined. Shiva, welcome, and you can ask questions. We're just at ultrasound. This looks like a solitary nodule. This is the ultrasound that he's just presented. Shiva, can you hear us? Maybe he has some technical issues. Okay, go ahead now. So now this is telling you there is one thyroids 3 and there is one subcentimetric nodule which is thyroids 5. What do you want to do?
So in this case, I would like to go for the FNAC of both the nodules, right as well as left.
Right.
So
What is the criteria? Yes, go ahead.
Yes, sir. So you're asking something.
What is the criteria of FNAC?
So it
Tell
should
me the
be
size versus criteria for FNAC of a thyroid nodule.
the size.
Characteristics of thyroid nodule versus you doing an FNAC of that nodule. When will you do it?
So if the age is less than 16 years or more than 55 years, if there is a family history, if there is radiation exposure in past, male gender, and yes, sir. These are the conditions in which I'll go for FNAC.
No, these are the conditions that the nodule is likely to be malignant. What you have said is that the nodule is likely to be malignant. I'm asking you on ultrasound, low risk, intermediate, high risk, what are the size cutoff for doing FNAC? If you
Ronak, in this case, if this was a 0.6 lesion, would you do an FNAC of that lesion?
Yes, sir. Yes, sir. I will do FNAC of this because this is more representative, looks like more malignant. So I'll do FNAC of this, sir.
If there wasn't these findings on ultrasound, would you do an FNAC of that lesion?
No, sir. Then I'll not.
So that's what Dr. David is asking you. What are the criteria for doing an FNAC?
Okay. So, sir, if it is this lesion is appearing irregular with microcalcifications, taller than vital, hypoechoic, solid component is there. So then I'll go for FNAC. And sir was asking about size. Then I don't know exact size.
You're talking of high risk features, and you're talking of size. So there are two criteria. One is just size based, and one is size and risk based. So the ATA has classified it, and the Radiology Association has also classified it based on size and risk. Can you tell us more about that?
So less than 1 centimeter, 1 to 4, and more than 4 centimeter.
On ultrasound. Okay, that's fine. So in this patient, there's a high risk lesion and you would want to FNAC it if you don't have any other diagnosis. Go ahead.
So sir, the FNAC of right side came out to be suspicious for papillary carcinoma, Bethesda category 5, and the left side, which was Tourette's 5, is papillary thyroid carcinoma, Bethesda category 6.
Ronak, can the host unmute Shiva? He can't unmute himself. So Ronak, if you find an nodule which is thyroid 5, do you FNAC any nodule that is less than a centimeter? What is the size cutoff? Basic cutoff?
So 1 centimeter, sir.
Then why do you want to FNA a nodule that is less than a centimeter?
So because it is Tourette's 5 high risk, this thing is this high risk features are there in this. So I want to.
So have you, right, good. Have you heard of observation of papillary thyroid carcinoma?
Yes, if it's less than 1 centimeter micro this papillary, then we can observe, sir.
Who has told you this? We can observe. What evidence do you have? What is the evidence for observation of a less than a centimeter nodule? Why are you saying that you will observe a less than 1 centimeter nodule?
Sorry, sir, I don't know. Yes.
Where does this come from? Do you know about the Ito's group from Japan, where they observed nodules less than a centimeter and followed them up, even those with high risk features? Or they observed actually papillary thyroid carcinomas that were less than a centimeter? Have you read Ito's paper?
No, sir, I have not read this.
Okay, so read that. So which nodule? Okay, so you know that less than 1 centimeter, you know that we will observe.
Yes, sir.
Which nodules less than 1 centimeter will you not observe? Okay, Ronak, you need to read that paper.
Yes,
Less
sir.
than a, it is called observation for micropapillary carcinoma. Nodules that are close to a recurrent nerve, those which make obtuse angle with the trachea, or those who are very close to the trachea and chances of infiltration if they grow, posteriorly placed nodules which are close to the nerve are usually not suitable for observation. All right.
Okay, sir.
So you
And
need to
also,
note-
Ronak, when you're looking at the nodules, just to complete the discussion, there's also a difference between the age of the patient. So in pediatric population, you would want to FNAC.
Yes, sir.
In adults, you may observe. Again, location in relation to the tracheoesophageal groove versus on the trachea. The risk, the nature of the nodule on ultrasound, as well as the size. So these are various criteria on which you will consider whether you'd want to FNAC the nodule or not. Okay.
Yes, sir.
Also, please read the ATA guidelines on FNAC of a nodule. If it is low risk, if it is high risk, then more than a centimeter, you need to FNAC. If it is intermediate risk, then the size is more than 1.5. And if it is low risk, then the size is more than 2 centimeters. Okay. So there are very specific guidelines that have been given for FNA of a thyroid nodule. Okay. Depending on the ultrasonography features of it.
Yes, sir.
Very good. Go ahead. So now one is you've got papillary thyroid carcinoma. We have discussed observation, but obviously you don't want to do that. So what are you going to do? So both nodules are on the right side, correct?
So the one which was feeling was on the right side, that is Bethesda 5, and the left
And it is
the other
Bethesda 5. Okay, suspicious. All right.
and
And the other one is confirmed malignancy.
Yes, sir, it's on the left side.
Okay. So what do you want to do?
So in this case, I would like to go for a total thyroidectomy. And so in this patient, so it's suspicious for PAPCA, Bethesda 5. So with the this thing, 60-70% chances are there that it's malignant, but still 30 to 40% chances are there that it is not malignant. So my plan would be, sir, that the plan would be total thyroidectomy. And regarding the central compartmental clearance, if the right side shows malignancy, which is confirmed on FS, then I'll go for central compartmental clearance. Otherwise, I'll not go for central compartmental clearance.
So Rana, would you be doing frozen section on this patient?
Yes, sir.
So what are your indications for frozen section?
The frozen section is that first thing is that on the clinical basis and history basis, is 32-year-old lady with a long-standing goiter, and on ultrasonography, which says it's a thyroid 3 lesion, and Bethesda category 5, which has malignancy chance of 60 to 70%. There are chances that it is not malignant also. So we can avoid central compartment clearance in that patient, sir, because the other nodule is only 0.6 centimeters.
So which side would you remove and send for frozen section?
I'll remove the right side and send for frozen, sir. And if it is coming malignant, then a T3, despite this sonography showing that there's no central compartment node, but in the T3, T4 tumor, it's a T3 tumor, then I'll go for central compartment clearance profile elective.
What is the nod? Which nodule is more suspicious, the right or the left?
Left is more suspicious.
So then if it comes as benign, you're going to leave behind a suspicious looking nodule?
No, sir. My plan is total thyroidectomy. But for the central, the plan will not change. The total thyroidectomy, it has to be done. But only for the central compartment clearance, I'll like to go for FS of the right side, frozen section.
Would you avoid an FNAC on this case, Ronak? Is FNAC avoidable in this case? If you have a 7-centimeter nodule, is there a role for observation in this case?
No, sir.
Then what is the role for FNAC? If you have very good frozen section facilities, if you have, then would you still do FNAC on this case?
So FNAC has to be done in this case. Had it come to be Bethesda category 6, then my plan would have been total thyroidectomy with central compartment clearance.
Central compartment clearance is a separate issue.
Yes, sir.
That sir will discuss with you.
Yes, sir.
But the role for surgery, is there a role for observation in this case?
No, sir.
If you have a 7-centimeter nodule on one side?
No, sir. This was to be removed. For that, it is not needed, sir.
To me, an ultrasound is very important because it tells you that yes, there's a nodule on the opposite side also, which I was not able to feel. So I'm going to explore that side. I will not end at just doing a frozen section on the right side and back out if it is benign. So ultrasound is very important. I want to only ask you if your plan is based on the ultrasound findings that surgery is to be done, then would you do an FNAC if you have good frozen section facilities?
So if I have good frozen section, then I can avoid FNAC, sir. Just
sometimes FNAC diagnosis is much better the papillary CA.
so in this case, we don't know. So it can be medullary thyroid carcinoma. It can be like FNAC has to be done. This.
Okay. So yes or no?
Say I will do FNAC and sir then proceed, sir.
Ronak, you are putting the noose around your neck. You now mentioned medullary CA thyroid in the same breath. And I'm going to ask you, what is the incidence of medullary CA thyroid?
The incidence is 10%. If it's a thyroid cancer, then 10-15% are medullary thyroid carcinoma.
You're just giving some strange statistics. And also tell me, what is the incidence of medullary CA thyroid patients presenting with a 7-centimeter nodule at age 32? With no other symptoms. What is the common presentation of medullary CA thyroid?
present with the neck swelling.
Where?
So they may present with the this neck node as
How
a.
many present with a goiter? How many present with lateral neck swellings? How many present in metastatic setting?
So I'm not sure about this.
Majority will present to you with lymph nodes,
Yes, sir.
right?
Yes, sir.
And again, it depends whether they are familial or sporadic. The younger the patients presenting would be more likely to, younger or very elderly would present with familial, and the ones that are sporadic are in the middle. So the most common presentation would be with lymph nodes in the lateral compartment.
Yes, sir.
So now we have to ask, you're not answered sir's question. Would you do an FNAC in this patient at all if your plan was a total thyroidectomy?
So
So it's a 7 centimeter nodule. Patient is cosmetically inclined towards surgery. Patient has come in to meet a doctor because apart from the swelling, there's no other symptom. On ultrasound, you have picked up a nodule on the other side,
yes, sir.
which looks suspicious. Would you still do an FNAC?
So if I have a frozen section available, then I can avoid this FNAC in this case.
And what if you didn't?
Side you said comes negative. Are you going to observe the opposite side?
No,
I
sir.
can understand what your plan is. See, Ronak, to understand treatment of thyroid, you have to know all the options available with you. Which ones less than a centimeter, even if ultrasound shows high risk features, you can still observe. You have to know this. Okay, you can observe, and some of them, many of them won't grow, right? So you could have easily only done a right hemithyrectomy and observed, not even done a FNAC of the left side. But now that you found it, you must treat it, right?
Yes, sir.
So what frozen are you going to do? Right side you sent for frozen comes negative. Are you not going to now operate the left side?
So I will operate the left side, sir.
So your plan has to be very clear. First, you did not have put a needle into a subcentimetric nodule. Okay, there is enough evidence to say that you should not FNAC a subcentimetric nodule in a young patient. But if you have got a papillary thyroid, now your plan is clear that that left has to go. The right is 6 centimeter nodule, which is Bethesda 5. So that has to go. So clearly you need now you need a total thyroidectomy. Unless the patient wants to observe, that is a different discussion altogether. And you must, all of you all who are attending must read the ETOS paper and lot of literature on observation of micropapillary carcinomas.
Yes, sir.
Okay?
Yes, sir.
All right. Okay.
Shiva, you want to ask him something? Shiva?
No, sir, not at present. It's going well.
So now, Ronak, coming to the central compartment. You're done a total thyroidectomy. This patient has a 0.6 centimeter nodule on the left side. You send it for frozen section and your pathologist reports it as a papillary CA thyroid. Right lobe is benign.
Yes, sir. So then,
How will you proceed?
sir, this sonography was N0.
As I was saying,
Devendra, we can't hear you.
Ronak,
Yes, sir.
what do you do for the central compartment? Sir was saying, let us discuss about central compartment. So 0.6 centimeter left side. Will you do central? Yes, no. Right side 6 centimeter frozen negative. What will be your extent of neck dissection if at all you want to do it?
So in this case, as sir has given the scenario, then I'll not go for central compartment clearance.
You will not go for central compartment clearance. Very good. What are the indications of central compartment dissection?
The indications will be a T3, T4 tumor. This T3, T4, T size is T3 or T4. Or if there is lateral group of lymph nodes which are present, so the chances 80% that central will be positive. So in that case, so, and if they are positive, then so 3 indications for going for central compartment clearance. And if it's a medullary thyroid carcinoma, then prophylactic has to be done.
You seem
What
to
is the
love
role of
medullary
CT scan?
CA thyroid.
No, sir. It's just for this indications I've told. But otherwise, for the DTC, these three indications are there, sir. If T3, T4, lateral is positive, or if the central compartment has lymph node. These are three indications.
Somebody in the chat has asked what is the role of CT scan or a PET CT in the workup of a thyroid nodule.
Devendra, you are not audible, Devendra.
Ronak, what is the role of CT scan or PET CT in a thyroid nodule? Somebody asked on the chat.
So, CT scan is needed if there is involvement of the aerodigestive tract, if there is dysphagia or this dyspnea is there. Second thing is that if there is gross lymph nodes which are there in the lateral compartment, so central compartment is 80% chances are there to be positive. Then for central compartment, this thing is needed CT scan, or the central compartment of the mediastinal group of lymph nodes are there. If there is a retrosternal extension, then this is necessary. And also to know the fat planes with the adjacent structures like the great vessels, we need to go for CT scans.
Okay, very good. Go ahead. So Pratyesh was asking your total thyroid number.
Devendra, we can't hear you.
Okay, though you were asking you after total thyroidectomy. So you have done a total thyroidectomy, you have not done a neck dissection.
Yes, sir. Yes, sir.
What would you do now post-operative? Do you have the histopathology of this patient? Have you operated this patient?
Yes, sir. So in the
Tell us.
in the right side, which was a larger one, it came out to be follicular adenoma, and the left side, which was 0.6 centimeters on the sonography, that came out to be the size was 0.3, and it was conventional differentiated PAPCA with lymphocytic thyroiditis. So T1A NX.
So what do you want to do?
So this I would like to stratify the patient. So this patient comes in a low risk group. So I'll not go for this radioactive iodine scan in this patient. And I like to follow up with this patient 12 to 24 months. Like this is the follow-up for low risk patients.
What is the risk stratification criteria?
So a low risk, intermediate risk, and high risk. So if there is no lymph node, or if there are lymph node less than 0.2 centimeter, 5 or less than 5, showing micromets, it's a low risk. If it is 0.2 to 3 centimeters, more than 5 lymph nodes, it's intermediate, and any node which is more than 3 centimeters high. If there is no extracellular extension, it's low. Then minimal is intermediate, and gross extrathyroidal extension is high risk. And if there is metastasis, it will fall into high risk group. If there is this post-operative thyroglobulin level is very high, then it will fall into high risk, which is suggestive of metastasis. Or if there is follicular neoplasm with more than 4 lymphovascular space in 4 lymphovascular emboli, then it falls into high risk. So the unfavorable histology falls in the intermediate risk, and yes,
Give radioiodine or not to give radioiodine?
so in this patient, I will not give radioactive iodine, sir.
Why?
So this,
Can you stage this? Can you stage this cancer, thyroid cancer, differentiated thyroid cancer?
so this stage is T1A. So clinical this T. So you want this now this to be staged. So just a T1A NX N0 M0. So this less than 55 years is stage 1.
And what is stage 2?
Stage 2 in less than 55 and more than, sorry, in less than 55 will be M1 disease. NET, NEN, M1.
And is there a stage 3?
Less than 55, it's not there, but more than 55, it's there.
Your answer has to be complete. You don't let the examiner go on asking you questions.
Yes, sir. So in this less than 55 years of age, it's there's only stage 1 and 2.
And above 55?
Above 55, sir, it's stage 1, 2, 3, and 4. 4 further divided into 4 and 4B.
So what is stage 3 and what is stage 4?
So stage 3 is T4A, NEN, M0, and stage 4A is T4B, N0, M0, and stage 4B is NET, NEN, M1.
So how will you observe this? How will you follow up this patient?
So the follow-up will be in 12 to 24 months, this low risk. And in the follow-up, I would like to ask her for the neck Doppler.
What is this 12 to 24 months? I'm not getting.
So the follow-ups are yearly follow-up, yearly or 2 yearly follow-up for this patient.
You wouldn't want to see her after surgery?
Yes, sir. After surgery, I would like to see her. I would like to see the histopath as this one. And after that, I'll start her on this Eltroxin.
So why do you want to call her after 1 year directly? Apart from your cancer management, what other things you will look at in the follow-up?
So the TSH I'll look for. I have to keep in this a particular range, 0.5 to 2 milli international unit per ml.
So you have to be very fluid when you're talking about follow-up treatment. Just the way you practice in your clinic, that's the way we want you to answer. So when I ask you, how will you follow up this patient? You have to talk in terms of the physiology of the patient. You're talking in terms of oncologic outcomes. And then in case you're doing any therapy, then what therapy you're going to give. So please tell me on these 3 lines.
Sir, regarding this patient, sir, when she comes with the report, since she falls in the low risk group, there is no need for reductive iodine scan. This and I'll prescribe her on Eltroxin early morning once a day for 100 microgram.
What is the dose?
So dose for this age will be 1 to 2 mcg per kg for this.
Okay.
Yes, sir. So her weight was approx 55. So this will come approx 110. So 100, I'll give 100 mcg.
So you'll start straight with 100.
Yes, sir.
How long does it take for the homeostasis of the thyroid levels?
Sorry, sir, I don't know this.
When will you repeat a TSH?
So TSH, I'll repeat 3 months.
Why 3 months? Okay, then what will you do at 3 months?
At 3 months, the patient comes to you with, she's on Eltroxin with a TG of 8. Thyroglobulin value of 8. How will you proceed? What will you do? She comes to your outpatient. She tells you my thyroglobulin is 8. I am on 100 or 150 milligram of Eltroxin. Manage the patient now.
So I would like to, in this case.
So for that, you need to know what is the half-life of half-life of TG, and what time does TG go to its base, the nadir of TG. Tell me answers of these 2 questions. What is the half-life of TG?
Will you do anti-thyroglobulin?
Yes, sir. Yes, sir. In follow-up,
Why would you do that?
So this TG can be false low if the antithyroglobulin is high. So this has to be done according to this. This has to be done according always with this thyroglobulin.
So at 3 months, what all investigations will you order?
So in this case, I'll order a thyroid function test.
Yeah,
So in 3 months, I'll order this only, sir.
only thyroid function test. Then how do you, Devendra asked you that thyroglobulin is 8. So it shouldn't have been done.
So I don't know about this, sir. Just have to read it.
How do you follow up a patient of thyroid cancer? One is ultrasound. It's why do you do a total thyroidectomy? Because your thyroglobulin is more sensitive, isn't it?
After total thyroidectomy, yes, sir.
Correct. Otherwise, why do you want to do a total thyroidectomy on this patient? One of the advantages of a total is that you can measure thyroglobulin, you can detect recurrence. That's how you detect a recurrence, right?
Yes, sir.
What are the types of responses, Ronak, you know of to surgery? Classify responses for me.
Response.
When will you say that patient has excellent response? Do you know of any classification?
No, sir.
These are practical points, Ronak. When a patient comes to you in OPD, you must categorize them as either excellent response, biochemical incomplete response, structurally incomplete response. And that is how you will take action. Now tell me, when does TG go down to base minimum, baseline? So when the TG report was 8, what comes to your mind first?
So remnant, this thyroid is there, sir. This.
Remnant thyroid. So where do you leave remnant thyroid? You have done total thyroidectomy. So tell me, where do you leave back remnant thyroids?
So the pyramidal lobe, thyrothymic ligament, in the Berry's ligament, and the superior this pole.
Okay, very good. So when the patient comes with a TG of 8, does it matter whether the patient is on L-troxin or off L-troxin? Do you want to know that?
Yes, sir. Unstimulated TG, we have to know, sir. Yes.
So this is stimulated or unstimulated, patient is on L-troxin. So tell me the cutoff of TGs where you are happy. So what TG level you will be happy when the patient comes for follow-up? Tell me unstimulated and tell me stimulated. Both. You have to know that because you need to know when to investigate the patient further.
Yes, sir. So I'm sorry, sir. I don't know this answer, so I'll find it out. Sir.
All right. This is very important, Ronak.
Yes,
This is
sir.
routine management of thyroid cancer in your OPD. You must know the importance of TG and you must know the role of anti-TG antibodies as Prathamesh asked. Okay?
Yes, sir.
Right. So what do you want to keep the TSH level as 0.5 to 2, you said. So can you classify them as high risk, intermediate and low risk?
So high will be less than 0.1, intermediate will be 0.1 to 0.5, and low will be 0.5 to 2.
Okay, great. Right. So we are getting answers on the stimulated versus unstimulated. Right. So anything less than 1, you're happy. If it's between 1 and 10, you're uncertain about whether there is disease, and more than 10, you have to start searching for residual disease. Okay.
Yes, sir.
Or recurrence.
So thyroglobulin has to reduce to a significant level within a month. So you need to actually look at the thyroglobulin at 3 months, which will actually reflect what exactly is the status of the thyroid tissue in the body.
Yes, sir.
So just for everybody, the half-life is about 3 to 5 days, about 65 hours. So the nadir of thyroglobulin is achieved in about 8 weeks. Okay. So at 3 months, when the patient comes to you, you should be expecting an extremely low thyroglobulin if you have done a good total thyroidectomy. If the thyroglobulin is high, either you have left back a little bit of thyroid tissue, then you continue to measure that thyroglobulin. And if the thyroglobulin is rising and it goes above the values that I told you, you need to investigate the patient further. All right, that is how you'll follow up a patient of thyroid cancer.
And about antithyroglobulin, how long does it take for it to reduce?
Sorry, sir.
Rana?
No,
How
I
long
don't.
does it take for antithyroglobulin to reduce in the body?
So I don't know, sir.
So it can take almost up to 1 to 2 years. So you need, once you have a baseline evaluation of antithyroglobulin, doesn't mean you need to, use that as your baseline. You may have to repeat it at the end of 1 year whilst you're doing your thyroglobulin. So on your follow-up, you should consider doing antithyroglobulin at the end of 1 year and at the end of 2 years.
Yes, sir.
You say to classify patient as low risk, right? What do you understand?
Devendra, we can't hear you.
To classify patient as low risk.
Yes, sir.
What do you understand by dynamic risk classification? Why
So
do you call it dynamic risk classification?
So dynamic risk classification is that the patient presently may be a low risk, but in time to come he may become high or intermediate. Or the patient today, if the patient is high risk, he might become low risk in time to come. So that's why it's dynamic. So low risk can become high and high can become intermediate or low risk. So that's fine.
See, Raurag, you must understand the concept of dynamic. Where is it most important? A high-risk patient is stable for 10 years and has no recurrence. Will you reduce the TSH suppression or reduce the intensity of the follow-up? That is the question.
Yes, sir. We'll reduce the this follow-up, sir.
No, Raurag. High-risk patient always continues to be a high risk. They do not reduce. An intermediate risk who's controlled for 5 to 10 years can come down. You can come down on the suppression and you can come down on the follow-up. So the maximum benefit of dynamic risk classification is for the intermediate risk group, where if the patient is controlled for a certain length of time, you can come down on the TSH suppression to low normal levels. Okay. But a high risk patient, remember, continues to be a high risk patient and you must suppress the patient and see him frequently.
Okay, sir.
All right. Okay. Should we go on to the parotid, Prathamesh, or just for completion, you want to ask for role of RT? Are there any chat questions?
No, I think we can go on to the parotid.
So any questions from your side?
No, I'm learning with Ronak.
So I wanted to ask one question, sir. So this
Yes.
age in ages 7 to 8 has changed from 45 to 55. Sir, is there any reason for changing this, sir?
There are at least 3-4 articles on which it is based, Ronak. There is an entire ATA, that's the American Thyroid Association guidelines, which have been reversed. I mean, they have shifted from 45 to 55 based on data which has emerged from North America, which had looked at the stage migration. And they found that the patients who were between 45 and 55 continue to remain low and intermediate risk. And that's the reason they found merit in shifting the age group, because more number of patients will continue to be disease free and have been unnecessarily labeled as high risk. So the problems of being labeled as high risk, as Devendra was alluding to, was the fact that you have to continuously suppress the thyroglobulin, the TSH. So you need to keep giving these patients replacement and suppression. So if you have a good chunk of patients that will move from high risk to low and intermediate risk, you can avoid that. So please read. There are a couple of articles which have on which basis the shift was made in TNN.
Okay, sir. Thank you, sir.
Thyroid, and there was, because it is in the chat, you've done a total thyroidectomy on this young lady. Second day, the calcium level is 6.9. How will you manage it?
This patient has hypocalcemia, so I like to give her IV calcium gluconate 10 ml in 100 ml NS 8 hourly.
How long?
Devendra, you're not audible, Devendra.
Ronak, for how long? Will you give just one bolus and follow it up with oral? Or will you give bolus and follow it up with a IV drip for 24 hours? How much of calcium does a 10 ml of calcium gluconate contain?
So 1 ml contains 95 mg and 10 ml will 950.
93. Right. So always, Ronak, it raises the calcium only for a few hours. So when you give IV calcium, you must follow it up with a drip of 500 to 1000 ml over 24 hours. Okay.
Okay, sir.
And then switch over to oral calcium.
Okay, sir.
Which oral calcium has the highest elemental calcium content?
Calcium carbonate.
How much? How much? Ronak, these are practical questions that you must know when you're managing a patient in the ward.
Yes, sir.
If the patient has achlorhydria, what preparation of calcium will you give? You must read hypocalcemia, Ronak. When you're presenting a thyroid case, you must read when you're doing a total thyroidectomy.
Yes, sir.
Okay.
Yes.
All right. Prathamesh, should we go on to the parotid?
Yeah, we should.
Maybe Shiva can join in.
Yes, sir. I'm in.
Yeah.
Okay, Kushal.
Everyone.
Shiva,
Good evening, sir.
good evening. Thank you for coming, Shiva. Thank you very much.
Thank you.
Is your video on, Shiva?
I've kept it off, sir, as of now. You want me to switch it on? I'll do that, sir.
Yeah, keep it on. Oh, good. So go ahead, Kushal. Please present.
Yes, sir. Good evening, everyone. Am I audible?
Yes.
Okay. Just a second. Patient Mrs. Poonam Mittal, 41-year-old lady, a homemaker resident of Mumbai, came with chief complaints of swelling below the left ear lobule since 1.5 years. Patient was all right 1.5 years back when she noticed a swelling below the left ear lobule, which was insidious in onset and gradually progressive. To begin with, it was of a size of a peanut and it has progressed to a size of a lemon presently. It is not associated with pain. There is no history of rapid increase in the size of the swelling. No history of facial asymmetry, drooling of saliva, inability to close eyes. No history of difficulty chewing or difficulty opening the mouth. No history of pain or increase in the size of the swelling on food intake. There is no history of difficulty swallowing, change in voice. There is no history of any intraoral swelling or any lesion in the oral cavity. There is no history of similar swelling on the contralateral side or any other area of the neck. However, patient gives a history of small skin nodule in front of the left ear, which is present since 20 years. There's no history of dryness of eyes, oral dryness, or pain and stiffness of the joints. There is no history of recent viral infection, fever, loss of weight or appetite, and night sweats. There's no history of cough, breathlessness, hemoptysis. There's no history of radiation exposure in the past. Past history, there's no significant medical or surgical history in the past. No history of similar swelling in the past. Personal history, patient consumes a mixed diet, sleep, bladder, bowel, appetite normal, no habituation to tobacco or alcohol. The summary of my history: a 41-year-old lady with a gradually progressive painless swelling below the left ear lobule since the past 1.5 years without any symptoms suggestive of facial nerve palsy. Sir, should I go ahead with examination?
Shiva?
Yes, I think we can discuss the management as such once the examination and the management subsequently, since I
Sure.
don't have any question as of now.
Okay. On examination, general examination, patient is conscious, cooperative, well-oriented, ECOG performance status 0, vital stable, no pallor, icterus, edema, generalized lymphadenopathy. On local examination, on inspection, a pea-sized skin nodule is noted just in front of the tragus. A single smooth spherical ill-defined swelling of about 3 by 3 centimeter is noted below, behind, and in front of the left ear. It is raising the left ear lobule and obliterating the normal hollow below the left ear. The skin over the swelling appears normal. No pulsation seen. On asking the patient to turn the head to the right, the swelling does not become less prominent. There is minimal decrease in the size of the swelling on mouth opening. No change on masseter muscle contraction. No swelling seen on the right, in the right parotid region. Inspection of the neck, no swelling is appreciable. Intraoral inspection.
Just a minute, we can
Yes.
just, so since you mentioned this in the examination and also the picture here depicts that small nodule,
Yes, sir.
what is its significance? You say it's present since 20 years. So what according to you is that?
Sir,
Is it relevant?
it's mostly a skin papilloma, sir.
Or is it an accessory auricle? Just looking at the clinical picture, it looks more like an accessory auricle than a.
Yes, sir.
Uh,
Could be, sir. Yes.
yeah. So the point I'm trying to make here is, I mean, you're emphasizing on the skin nodule way too much, which may take the direction in a different way. So you
Okay.
just have to give as much emphasis as it is required and not
Yes.
mention it all too
Yes.
often.
Yes.
And what is the importance of showing this examination of oral cavity in this case?
Sir, this is a swelling in the left parotid region. I will have to complete my examination to confirm whether it is a parotid swelling. But a parotid enlargement of the deep lobe of the parotid gland may show a bulge in the left side tonsillar region in the left pharyngeal wall, which can be appreciated intraorally, sir.
Right.
As well as I would want to see any lesion in the oral cavity, because this can be I'm not very sure right now, but this could be a lymph nodal swelling also.
Okay. Fair
Yes.
enough.
Yes.
Lymph node metastasis is more common from which area?
Sorry,
of the
sir.
head and neck? Parotid lymph node metastasis is
Yes, sir.
more common from which area of the head and neck?
Sir, eyelids and forehead, scalp,
Yeah.
and then RMT cheek lesion can also present with a parotid lymph node, sir.
So more common in the eyelid scalp area.
Yes, sir.
not
Yes, sir.
so
More
much in the-
common in eyelid and scalp. Yes, sir.
How
Good,
often
good.
do you find intraparotid lymph node in oral cancers?
Sir, I don't know the exact percentage, sir.
So in an N plus neck, let's not discuss about N0. Let's presume it's insignificant. In an N
Yes.
plus neck, how often do you expect an intraparotid node?
Sir, as of now, sir, we don't see it that often. As I said, sir, I don't know the exact percentage, but usually,
Usually it is 4 to 6% in an N plus neck, and usually it happens when the lesion is coming out closer to the commissure and some not exactly an RMT, or when there is extensive involvement of the skin, you
Yes.
might find it. But that's why it's very less common even in an N plus
Yes.
neck. That's
Yes.
the bottom line.
yes,
It's less than 3%. And as Shiva said rightly, the more likelihood is when it involves the skin, dermal lymphatics.
okay, sir. Yes, sir. Sir, on sir, there is no lesion seen in the scalp forehead or eyelid. No discharge from the parotid duct on intraoral examination, sir. Cranial nerve examination of 7, 9, 10, 11, 12 nerves is normal. On palpation, findings of the inspection are confirmed. No local rise of temperature or tenderness. A smooth, well-defined spherical swelling of about 3 by 3 centimeter is palpable below, behind, and in front of left ear. It is firm in consistency and mobile in all directions. Skin over the swelling is free. It is also free from underlying masseter. Curtain sign is positive. Superficial temporal artery is palpable above the swelling. Parotid duct palpation, no abnormality, no palpable abnormality. Intraoral deep lobe is not palpable on bidigital examination. Terminal part of the parotid duct, no abnormality is palpable. No cervical lymphadenopathy palpable. Contralateral parotid submandibular region is normal. Left external auditory canal is normal.
So one question: how do you palpate the parotid duct, and how often, and why do you do that, and how often do you do that?
Sir, parotid duct palpation, sir, the proximal part is usually we ask the patient to clench the teeth so that the masseter become taut, and we palpate it around 1.5 centimeter below the zygomatic arch by rolling our fingers over the taut masseter. The distal part of the parotid duct is palpated by digitally by keeping the thumb inside the cheek and the index finger outside, and we feel the submucosal part of the parotid duct, sir.
What is its significance? What are you trying to rule out or rule in by doing that examination?
One is if there is malignancy, then whether there is extension of malignancy going towards the parotid duct. Secondly, the not in this case, but sir, parotid duct stone which can be palpated, sir.
Right. And even if the disease is passing through the duct, how is it going to influence your management is what I'm curious to know.
Sir, the parotid duct arises from the deep lobe of the gland, sir. So if the parotid duct is involved, then the deep lobe and patient will require a total conservative or total parotidectomy.
So I'm not aware of any such. I'm not sure. I'm not aware of this finding. I mean, Chauka sir or Pradhan sir or Pai sir can just comment on that. Hello.
Yes, sir.
Yeah. No, but the significance. It's not just that the duct arises, of course, from part of the deep lobe as well, predominantly, but then it has contributions from the superficial lobe.
It has.
And it doesn't per se say that, in fact, the main contribution comes from the superficial lobe, does not particularly say that it may arise from the deep lobe or otherwise. And yes, it may be a case, but then it's not as foolproof as what you say. That's my point here. It needs to be corroborated with imaging.
Right.
Go ahead. Yeah. Hello.
So go ahead.
Go ahead, please.
Sir, sorry, sir, the mic went mute. The summary of my case is a 41-year-old lady with gradually progressive painless left parotid swelling since the past 1.5 years with no features of facial nerve palsy or cervical lymph nodal involvement. Am I audible?
Yeah, you are.
Yeah.
Yes.
Go on.
Yes. Sir, as my differential is a parotid swelling, I would like to investigate the patient. I would want to do a sonography of the neck, including the parotid, as well as a sonographic guided FNAC of the parotid lesion, sir.
What would be the better investigation for a parotid lesion? Of course, you can do a ultrasound guided FNAC, but then...
Sir, my initial investigation would be a sonography. Sonography will give me the information about the... it will, first of all, it will confirm that the swelling is arising from the organ which I'm suspecting, that is parotid. Secondly, the sonography will give me a rough idea about the local extent as well as the regional extent. In local extent, it will tell me, first of all, it will tell me the nature of the swelling, whether it is solid, whether there is any cystic component. It will give me the size of the swelling. It will give me a rough idea about the relationship with the adjacent structures. It will give me a idea about whether there is any deep lobe involvement. It will give me idea about the opposite parotid.
So deep lobe with an ultrasound?
Yes, sir. It will give you a rough idea, sir. It's not a very good investigation for a deep lobe because it is retroparotid, retromandibular in placement, sir. The deep lobe, but a rough idea can be obtained, sir. It won't be definite, but yes, sir. It's a rough idea can be obtained. Sir, then it will also give me the regional lymph nodal extent.
The only
Yes, sir.
drawback of ultrasound is
Yes.
that it cannot differentiate between superficial and deep lobe.
Yes, sir.
And that is why one of the indications of MRI apart from PNI is
Yes.
to differentiate the location of the swelling, whether it is superficial lobe or deep lobe,
Yes, sir.
because you are sometimes foxed by a deep lobe swelling which presents as a superficial lobe.
Yes.
So ultrasound, you said all the features correctly, and you're right by saying it is the first, but it cannot differentiate. That is one of the drawback of ultrasound.
Yes. Sir,
So in this patient, Kushal, where do you expect the lesion to be, superficial or deep?
sir, clinically it looks superficial, arising from the superficial lobe. Clinically, there was no intraoral swelling, or I could not appreciate any on digital examination any swelling. So, sir, it looks like to be arising from the superficial lobe, although it is in the tail
So
parotid region.
what are the signs that will tell you that this is a deep lobe tumor?
Sir, one is the intraorally, I will see a swelling in the tonsillar region.
Always.
Not always, sir.
Okay.
Yes, sir. And sir, the relationship with the adjacent structures present in that deep lobe, sir.
So where is the deep lobe?
Sir, it is present in the prestyloid space in the parapharyngeal, prestyloid area of the parapharyngeal space.
Right.
Yes,
So
sir.
it is lateral to the mandible.
Yes, sir.
So what is the most important finding when you have a deep lobe involvement? What happens to the ear lobule?
Sir, raising of the ear lobule, sir.
That is what happens, right? You are looking at a preauricular lesion and a retromandibular lesion.
Yes, sir.
So something which is retromandibular will cause an elevation of the ear lobule or structures adjacent to it. So it gives you a clear idea whether this lesion is only preauricular or is now going and involving the deep lobe parotid.
Yes, sir.
Okay, go on.
Sir, this was the sonography report, a well-defined irregular hypoechoic lesion of 3 into 2.4 by 3.4 centimeter with no internal vascularity in the superficial lobe with mild extension into the deep lobe. A few reactive nodes bilaterally, findings suggestive of benign lesion in the left parotid gland like pleomorphic adenoma. USG guided FNAC was suggestive of pleomorphic adenoma, sir.
Why do you want to do FNAC? Tell me the advantages of doing an FNAC.
Sir, the reason to do FNAC is that it will help me have a better pre-operative it will guide me towards a better pre-operative counseling of the patient if I know the diagnosis beforehand. Secondly, sir, it will help me better management of the lymph node. I will plan it will help me better surgical planning. And thirdly, sir, the studies have shown that FNAC, preoperative FNAC can change the plan of treatment, plan of surgery majorly in approximately 30% of the cases. And lastly, sir, if it turns out to be a Warden's tumor, then there is a concept of virtual waiting in that case.
Give you three things. One, it will
Sir,
tell you plastic or a non-plastic.
sorry, sir.
Devendra, we can't hear you.
FNAC will give you three things.
Yes,
One,
sir.
is it a neoplastic versus a non-neoplastic? That is the
Yes.
first thing. So
Yes.
is it inflammatory? All right. Can you
Yes.
observe this swelling or treat it differently?
Yes, sir.
Second, where if it is neoplastic, is it benign or is it malignant?
Yes.
Okay, so that will give you the roadmap that you were talking about.
Yes.
And third thing, if it is malignant, you want to know whether it is low grade or high grade, which usually the FNAC cannot differentiate.
Yes, sir.
All right, unless it is very high grade.
Yes.
All right. So
Yes.
these are the key indications. And as you correctly said, if that is a Warthin's tumor, especially in the elderly male, or if patient is high risk for surgery, has comorbidities, then there is a case in point for observation.
Yes, sir.
Why will you not observe a pleomorphic adenoma then? What will happen?
Sir, there are 3 to 5% chances of malignant transformation of pleomorphic adenoma, and secondly, the increase in size may cause involvement of the facial nerve and morbidity associated with it.
Yeah, very good.
Yes.
Is there any reporting system just like the Bethesda for parotid lesions?
Yes, sir. There
I
is a
don't need.
Milan system for salivary gland FNAC. It is dividing into 1 to 6. 1 is non-diagnostic, 2 is non-neoplastic, 3 is a type of undetermined significance, 4 is neoplasm, which can be benign or salivary gland neoplasm of uncertain malignant potential. 5 is suspicious for malignancy, and 6 is malignancy.
Actually, the Milan system has been slightly revised recently, and now there is 7 categories. I mean, the 1 and 2 remain the same, that is non-diagnostic and non-neoplastic.
Yes, sir.
The type 3 they've classified as benign. Type 4 they classify as salivary lesion of uncertain malignant potential, also known as slump.
Yes, sir.
Type 5 as suspicious for malignancy, and type 6 they've divided as A and B, A being low grade salivary gland neoplasm and B being high grade, and type 7 as hematological malignant neoplasm.
Okay.
So what you said is right. That is the first Milan system. What I said now is the modified version of that Milan system.
Thank you, sir. Yes, sir. Since the sonography in this case is showing mild extension into deep lobe, and my clinical examination there was elevation of ear lobule, I would want to do a MRI in this case, sir. May I show the MRI, sir?
Now, why you want an MRI in this patient?
Sir, the sonography is showing deep lobe, mild extension into deep lobe. I would want to know the exact extent of the tumor into the deep lobe so that I can plan surgery, sir.
Does it change your plan of management?
Sir, I would know the relationship of the structures associated with deep lobe. So that way, sir, it might change the plan of treatment.
How will it change?
Sir, if there is significant extent into the pre-styloid space, then the structures involved may have to be sacrificed, sir.
We are
With
with a pleomorphic adenoma.
Yes, sir. It's a pleomorphic adenoma, but sir, still, if the structures are nearby, then I would have to explain the patient the possibility of injury to those structures.
So now you will not explain to them.
Yes, sir, I will.
So what is your counseling in a patient with pleomorphic adenoma?
Sir, the counseling is I would explain the possibility of injury to the structures. I would explain
What structures? What structures?
Sir, the greater auricular nerve, the injury to the branches of the facial nerve, sir, the possibility of post-operative seroma, sir, although less, but chances of wound infection, sir, the chances of recurrence associated with pleomorphic adenoma, and in case the final histopathology turns out to be something malignant, then the chances of whether a reoperation to do the neck or the adjuvant therapy which might be required.
So now you're done MRI. How will it change this consent?
Sir, I would by MRI I would also know the it's a pleomorphic adenoma, but usually MRI
So
can
what
tell me.
surgery would you do for this patient?
Sir, this patient, I would do a total conservative parotidectomy, sir.
So you need to justify that if I have an ultrasound, my plan is going to be a total conservative nerve sparing parotidectomy.
Yes, sir.
I will not require any further imaging.
Yes.
Now you are talking about a situation where you may have a malignancy, you may have involvement of deeper structures such as the muscles, the bone, the vessels coming onto the external canal, having lymph nodes.
Yes, sir.
So those are the situations which are clearly in a patient who has symptoms wherein you would want to do an MRI to be pre-warned about the extent of the lesion.
Yes, sir.
So you need to look at the case in front of you and then justify which investigations you're going to do.
Yes. Sir, in the
So have you operated this patient?
sir, I do not have the histopathology, sir.
Okay.
Yes.
So this comes as a 3 by 2.5 centimeter pleomorphic adenoma,
Yes, sir.
and they have commented on margins being involved. What's your plan of action?
Sir, I would want to recheck I would ask them to recheck the margins, whether it is focally positive or it is diffuse positive. If the margin is focally positive, then sir, actually there is no concept of margin in cases of uh, parotid tumors. It's just a full capsular complete excision of the tumor in benign parotid tumors. If the margin is diffusely positive, then repeat surgery will be required, sir, to clear the whatever tissue is left, sir.
So you need to look at your surgical notes,
Yes, sir.
and then you would need to look at any imaging that you have to corroborate whether that is a possibility.
Yes.
Would you remove this as one specimen or you'll have multiple pieces?
Sir, mostly it will be multiple pieces. It's a tail parotid lesion. I may try to remove it as a one specimen, but the usually if you have to do we first do a superficial parotidectomy and then we lift off the nerve away from the deep lobe, and then we do a deep then we remove the deep lobe. But in this case, it's lower down, so one specimen can be attempted, sir. Sir, am I?
Parotid is for me. Start from what is the role of enucleation versus extracapsular dissection versus superficial parotidectomy for a superficial parotid pleomorphic adenoma. Say the deep lobe was not
Devendra,
involved.
can't hear.
Say the deep lobe was not involved, Kushal.
Yes, sir.
Can you tell us what are the different parotid surgeries that
Yes,
are
sir.
possible, and tell me the difference between an enucleation, extracapsular dissection, and a superficial parotidectomy?
Yes, sir. Sir, the different types of parotidectomy, recently, sir, the European Salivary Gland Society has divided parotidectomy into two types. One is parotidectomy, the other one is extracapsular dissection. The basic difference is in parotidectomy, the two criteria which have to be fulfilled. One is the facial nerve has to be dissected and identified at the trunk, and at least one of the divisions of the facial nerve have to be identified, and at least one level of the parotid gland has to be removed. In extracapsular dissection, any of the two criteria have to be fulfilled. Either the facial nerve need not to be dissected, or less than one level of parotid gland has to be removed. Sir, extracapsular dissection versus superficial parotidectomy has been studied for benign parotid tumors in PRISMA study, and it was shown that extracapsular dissection is equivalent in terms of recurrence, as well as there was less facial nerve temporary as well as permanent temporary paresis as well as permanent paralysis of the facial nerve. Sir, enucleation is currently not practiced. It is associated with very high risk of recurrence, as was shown by the study by Robert Witt, in which he has shown that enucleation may be associated with as high as 45% chances of recurrence in benign parotid tumors.
The only thing is enucleation, you incise the capsule and you enucleate the tumor out.
Sorry, sir?
Extracapsular, just go around the capsule.
Yes, sir.
Facial nerve. And in superficial parotid, you dissect the facial nerve, as you said.
Yes.
You mentioned this European classification. Can you tell us what this European classification is all about?
So the European classification, in which they have divided the parotid gland into different levels. The superficial superior is level 1, superficial inferior is level 2, deep inferior is level 3, deep superior is level 4, and accessory lobe is level 5. So depending on the parotidectomy we are doing, suppose in this case we are doing a total conservative parotidectomy, then the nomenclature would be a left parotidectomy 1 to 4. And any of the non-parotid structures, if removed, have to be specified separately. Like if the facial nerve is removed, then you have to mention left parotidectomy 1 to 4 with 7 in brackets, or any other structure like masseter muscle, skin, bone, whatever is removed has to be mentioned separately. In an extracapsular dissection, the nomenclature is we have to first specify the side that is left, then we have to write extracapsular dissection. And then the next thing is the tumor, in which level the tumor was present. If the tumor was present level 1, then it will be 1. If the tumor was present at level 2, then it will be ECD 2. So yes, sir, that's how it is done. So a superficial parotidectomy will be parotidectomy 1 2 only. It won't be parotidectomy 1 to 4. Sir, sorry.
Devendra, we can't hear you.
So for uniformity, you have to write which level of parotid tissue you have taken out.
Yes,
because
sir.
there was a lot of confusion. People
Yes.
used to write superficial, some used to write adequate, some write partial parotidectomy.
Yes,
now
sir.
you have to write which level, as you said correctly, of parotid we have removed, and that is why the European classification is
Yes.
right. Okay, Kushal,
Yes, sir.
where will you address the lymph nodes? What will you do for lymph nodes? Because we know the fallacy of FNAC
Yes, sir.
is that it is very difficult to differentiate between a benign tumor and a low-grade malignancy.
Yes, sir.
Generally, they tell you a high grade, but that is also quite difficult. But generally, they'll be able to tell you.
Yes,
So,
sir.
how do you manage lymph nodes in a parotid tumor?
Sir, the usual practice we follow is to send the parotidectomy specimen for frozen section. Frozen section is very good for to tell us about the malignancy, as well as frozen section can tell us about the grade of the tumor. It might not tell us the exact histopathology of the tumor, but grade, and it can confirm that it is malignant, one, and secondly, it can also confirm whether it is high grade or not high grade. So if the frozen section reports come out to be high grade, then I would address the lymph node then and there. I would do a elective lymph nodal dissection even if the patient is clinically N0.
How often can the pathologist say whether it is what the grade and all in your frozen section?
Sir, I am not aware of the exact percentage, but the studies have shown that the sensitivity of finding a malignancy on frozen section is somewhere around 99%, and the specificity is 90%. So, sir, I don't know the exact
Say
percentage.
whether it is benign or malignant, but I'm not
Yes.
sure how often they can say
sir.
whether it's low, intermediate, or high grade.
Yes, sir. Actually it's easy to say high grade, but low grade and
It's
yes, is difficult to say whether it is low or intermediate grades.
it's not easy to say any of the grades actually. It
Okay.
depends because the histopathology of salivary gland tumor is so diverse. There
Yes,
are
sir.
multiple types, and you require a lot of IHCs to actually characterize and even grade. You need, as to what the grade is of, whether it's high grade or low grade. Is not just based on the histopathology. It is also based on what is the Ki-57 index, the
Yes.
mitosis, and all those things. So those determine the grade, not
Yes.
just your histopathology. So that cannot be always said in your
Okay, sir.
frozen. They can just give you an idea as to it may be high grade or it may be intermediate grade.
Yes, sir.
Would you send a lymph node for frozen section?
Sir, for benign swelling, I won't, sir.
So how do you know it's benign?
It's like I said that we usually send it for frozen section, and they are at frozen section they are mostly able to tell whether there is any malignant component. If there is, then we sample the subdigastric lymph node. As I said, sir, if they are very confirmed about the grade, they say that it is high grade, then we address we do a elective neck dissection. Otherwise, we sample the subdigastric level 2 lymph node, and we send it for frozen section and see, sir.
The sensitivity and specificity for frozen that you said is essentially to say whether it's benign or malignant.
Yes,
Not
sir.
exactly to say whether what the grade is. That
Yes,
you
sir.
need to
High grade.
understand.
Yes, sir.
Yeah.
Yes.
Kushal, you have
Yes,
told
sir.
us one indication of dissection for others. Can you tell
Devendra,
us
we can't hear you. Devendra.
Kushal, can you tell us the indications of neck dissection? And two, the extent of neck dissection for a N0 versus a N plus neck.
Sir, the indications of neck dissection is one, a T3 malignant disease, T3, T4, a high grade tumor with perineural invasions. Sir, clinically positive lymph node. For elective neck dissection, we the levels are level 2, 3, and 4, and for a positive neck, it is level 1 to 5.
N0 neck, the chances of level 1 and 5 are less than 4%.
Yes, sir.
Right. Okay.
If it is an adenoid cystic carcinoma
Yes, sir.
with an N0 neck,
Yes, sir.
will you do a full neck dissection?
Sir,
Or
I
you
would
do
do
no
a
sample?
elective. I would do a elective neck dissection in that case. Adenoid cystic carcinoma is a high grade carcinoma with a high chances of perineural invasion. I would do a elective neck dissection in that case. I would do level 2, 3, 4.
In all adenoid cystics,
Uh,
which is the high grade among the different adenoid cystics? Has cystic carcinoma is also having a grade, right?
Sir, I'm not aware, sir.
It might be an intermediate or a high grade. What are the types of adenoid cystic?
Sir, I'm not aware of the types of adenoid cystics.
Cribriform,
Okay, sir.
right?
Yes.
Kushal, what classifies adenoid cystic as high grade?
So the adenoid cystic carcinomas have a very high propensity of perineural invasion, and as well as there
When
are.
do you say adenoid cystic is high grade?
Yes, sir.
When does the pathologist say that? There is a particular criteria for that.
I'm not aware of the criteria, sir.
More than 30% solid component classifies it as high grade.
Okay, sir.
And all adenoid cystic are not high grade and do not have lymph node metastasis.
Okay, sir.
Okay, so what you said initially is that most of these cases where you don't know the grade, you'll pick up level 2 and send it for frozen section.
Yes, sir.
Okay, that is the normal practice that we all perform.
Yes, sir.
Okay. So do we have the histopathology of this patient?
No, sir. I don't have the histopathology.
Okay.
Yes.
So can you tell us the indications of post-operative radiotherapy in a parotid neoplasm?
Sir, post-operative radiation therapy is one T3, T4 tumors, high-grade tumors with perineural invasion, node positive tumors, as well as positive margin and closed margin has also been said as one of the indications of post-operative radiation therapy.
So there's a question in the box. How will you manage the facial nerve intraoperatively? And when will you resect the facial nerve?
Sir, in a functioning facial nerve, I would make every attempt to preserve the nerve. Intraoperatively, identification of the nerve and then dissecting along the over the plane of the nerve is the usual way of preventing its damage. Sir, resection is usually considered if there is the branches of the nerve are directly going into the tumor and there is no way it can be preserved, sir. But if the nerve is functioning, then every attempt will be made to preserve it.
So you said that adenoid cystic has high incidence of perineural in
Yes, sir.
patient.
Yes, sir.
So will you resect the nerve and send it for frozen section?
Sir, if the
If
nerve
it is not
is
involved,
if not involved, no, sir, I would not resect. Sir,
When would you use intraoperative nerve monitoring?
Sir, nerve monitoring is a preferred way of prevention of nerve damage in a recurrent case. In a upfront case, nerve monitoring has been studied, but there have been studies that have shown that it reduces the chances of injury to the nerve. But the problem with nerve monitor is that it reduces the chances of temporary paralysis and not exactly the chances of permanent paralysis.
Right.
Yes.
So will it help you when you have to make a decision whether you want to resect the nerve?
Yes, sir. Clinically, if the patient is if the nerve is functioning and intraoperatively during surgery, if the nerve monitor is also showing that the nerve is functioning, then I can then while dissecting it, it might help me preventing the injury to the nerve.
So nerve identification is important.
Yes, sir.
And then when you're planning to do a reconstruction, intraoperative nerve monitoring may help guide you towards the intactness of the nerve and
Yes.
whether it is going to be futile.
Yes.
Two, when would you do the intraoperative nerve monitoring in 3 situations? 1, extracapsular dissection,
Yes, sir.
adequate parotidectomy,
Yes.
and superficial parotidectomy.
Yes. Sir, in extracapsular dissection, I would use a nerve monitor because extracapsular dissection we usually one of the criteria of extracapsular dissection is that nerve is not identified. So in that case, a nerve monitor will be very helpful.
Right.
Yes.
Adequate parotidectomy.
Sir, adequate parotidectomy, we usually identify the nerve. So in that case, adequate parotidectomy is removing.
So how is it different from superficial parotidectomy?
Sir, adequate parotidectomy is removing the tumor with a cuff of normal parotid tissue around it. After identifying the nerve, in superficial parotidectomy, we remove the superficial gland, even if not necessary. Even if it is not, even if the level of that region of parotid is not involved, then also we remove it.
So what is adequate parotidectomy?
Sir, the definition of adequate parotidectomy is to remove the tumor with a cuff of normal parotid tissue around it.
And leave behind a functional tissue.
Yes, sir. Yes. Leave behind. Yes.
So it is important to use nerve monitoring.
Okay,
because
sir.
you would need to identify, because you're going to open the capsule, do a resection of the lesion with an adequate cuff of tissue, and then close the capsule.
Yes.
When would you give post-operative radiation in pleomorphic adenoma?
Sir, the usual radiation has been used in cases of recurrent pleomorphic adenoma. Although the usual treatment of recurrent pleomorphic adenoma is surgery, if there are multiple recurrences in which multiple multiple attempt have been made to resect the tumor and still there is recurrence, then in that case I can consider giving radiation therapy.
Right.
Yes.
Tumor thinking it's a pleomorphic adenoma,
Yes, sir.
in fact, as a mucoepidermoid carcinoma. What will you?
So if it turns out to be mucoepidermoid carcinoma,
Yes.
sir, mucoepidermoid carcinoma can be low grade mucoepidermoid or high grade mucoepidermoid. If it's the final histopathology or sir the frozen section says.
In final histopathology. Final.
Sir, if it's a low grade mucoepidermoid carcinoma, then sir, I would observe. I would not give radiation therapy if I have done a complete excision.
Very good.
If it's a high grade pleomorphic adenoma, then sir, I've got two options. If the patient is clinically N0, then I can electively radiate the neck. The other option is that I can do elective lymph node dissection. And then
So
then
if it is,
yes.
So if it is low grade, observe. If it is intermediate, bordering towards high grade or high grade,
Yes,
give
sir.
radiation. And as you correctly said, that you need not go in for a N0 neck again and operate the neck. If
Yes,
it
sir.
is clinico-radiological N0,
Yes, sir.
you can then radiate the neck electively.
Yes, sir.
That is why the practice of sending level 2 for frozen section gives you an indication that the node was negative, that the lymph nodes were negative.
Yes.
Shiva, Prathamesh, any questions? So,
I think we are done.
Yes, sir.
Lot
So any
more work
questions
to be
from your
done
side?
now for both the boys, particularly for Ronak. But thank you very much. Prathamesh, Devendra, Shiva, thanks a lot. There are
That was mine.
some questions on the chat if you want to answer them.
So we've answered most of them, some on the chat.
Okay, okay, okay. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir. Thank you all.
Thank you, sir.